My name is Gary Zaloga, and today I will be discussing advances in lipid emulsions, Emergence of Clinolipid. This is part 3 of a 3-part series. In part 1, I discussed the biological functions and nomenclature for fatty acids. In part 2, I discussed immune effects of fatty acids. In this part 3, I will discuss clinical results and implications of using an olive oil-based lipid emulsion. I would like to point out 2 potential conflicts of interest. 1, I was a previous employee of Baxter Healthcare from 2006 to 2016. Currently, I am a consultant for Baxter Healthcare. Clinolipid is a lipid emulsion composed of 80% olive oil and 20% soybean oil. Clinolipid is indicated in adults for providing a source of calories and essential fatty acids for parenteral nutrition when oral or enteral nutrition is not possible, insufficient, or contraindicated. Clinolipid injection is not indicated for use in pediatric patients because there is insufficient data to demonstrate that clinolipid injection provides sufficient amounts of essential fatty acids in this population. The omega-3 omega-6 fatty acid ratio in clinolipid injection has not been shown to improve clinical outcomes compared to other intravenous lipid emulsions. Clinolipid is a product available on the U.S. market for a year. Throughout the world, Baxter's olive oil-based intravenous lipid emulsion has been used as part of parenteral nutrition in a variety of patients, such as patients with critical illness, following surgery, and in patients with inflammatory bowel disease, short bowel, infections, respiratory failure, multiple organ failure, and hemodynamic instability. It has also been used in both short and long-term, including home, parenteral nutrition. Please see the end of the presentation for indications and important risk information, including the black box warning. There are many tests which assess human immune functions. These tests include immune cell functions of lymphocytes, neutrophils, and macrophages, and include proliferation, phagocytosis, adhesion, transmigration, and chemotaxis assays. Other tests include immune cell activation, antibody responses to antigens, cytokine levels, inflammatory mediators, delayed cutaneous hypersensitivity, and organ rejection. Unfortunately, many of these tests have limited availability for routine clinical use. However, many of these tests have been used in research studies. In this study by Granado and colleagues, human lymphocytes were exposed to an olive oil-based lipid emulsion or a soybean oil-based lipid emulsion. Proliferation as a monitor of clonal expansion was stimulated and measured by radio-labeled thymidine incorporation. It is clear that increasing concentrations of the soybean lipid emulsion suppressed lymphocyte proliferation, while the olive oil-based lipid emulsion demonstrated a neutral effect. Leukocyte adhesion to vascular endothelium and migration-emigration through vascular pores are essential biologic processes for leukocytes to get to target areas, such as infection, tissue injury, or cancer. In this study, adhesion and emigration were assessed in an animal model following exposure to control, no lipid in gray, clinolaic, and olive soybean oil-based lipid emulsion in green, soybean oil lipid emulsion in red, or an MCT soybean lipid emulsion in orange. The soybean oil emulsion and the MCT soybean lipid emulsion suppressed both cellular responses, while the olive oil-based lipid emulsion had a neutral effect similar to the control. This study was performed to determine if home parenteral nutrition patients receiving an olive oil-based lipid emulsion have compromised cell-mediated immunity. Neutrophils from home PN patients receiving an olive oil-based lipid were compared to those of healthy controls not receiving parenteral nutrition. The investigators assessed the ability of the patient's neutrophils to eliminate a bacterium known as Streptococcus pneumoniae, the bacterium responsible for pneumococcal pneumonia. There was no difference between the patients and healthy controls in bacterial elimination, suggesting that the olive oil-based parenteral nutrition did not impair cell-mediated immunity. Jia et al. Compared an olive oil-based lipid to a soybean-based lipid when used as part of complete parenteral nutrition in 458 surgical patients. Patients requiring parenteral nutrition were randomized across 18 hospital centers to the olive oil or the soybean oil-based lipid emulsion. Energy goals for parenteral nutrition were 25 kcals per kilogram per day, and parenteral nutrition was administered for 5 to 14 days. The olive and soybean groups were comparable for sex, race, age, BMI, and surgery. The duration of treatment was similar between groups, averaging approximately 8 days. Treatment compliance was similar and exceeded 99% in both groups. Prealbumin was used as an indicator of the underlying inflammatory status of the patient groups. Prealbumin increased in the olive oil group and decreased in the soybean oil group, being significantly different on day 5 between groups. The results suggest that inflammatory status increased on the soybean oil lipid and was the same or lower on the olive oil-based lipid. Total infections were significantly lower on the olive oil lipid compared to the soybean oil lipid. The primary difference in infections was related to lower respiratory or lung infections in the olive oil-based group. Strengths of this study included the large population, 458 patients, the prospective randomized multi-center design, the long duration of treatment of 8 days, this is longer than most previous studies, attainment of caloric goals, and 99% compliance with the protocol. Limitations of the study include use of a ready-to-use multi-chamber bag in the olive oil group versus compounded PN in the soybean oil group. Only elective surgery patients were studied, so results may not apply to other patient groups. And finally, the study was not blinded. Guidelines from ASPEN and SCCM recommend the following in regard to lipid emulsions for parenteral nutrition. We suggest withholding or limiting soybean oil-based intravenous fat emulsions during the first week following initiation of parenteral nutrition in the critically ill patient to a maximum of 100 grams per week, often divided into 2 doses if there is concern for essential fatty acid deficiency. This recommendation was made because of worry over the detrimental inflammatory and immune effects of using soybean oil-based lipids. The guidelines went on to suggest that substitution of an alternative intravenous fat emulsion for parenteral nutrition, particularly an olive oil-based preparation, may improve outcomes when compared with the more standard soybean oil-based products. I would add that olive oil-based lipids could be started as soon as PN is initiated. Now for some clinical applications. Which lipid emulsion is best indicated in my patient? The majority of experts believe that 100% soybean oil-based emulsions should be replaced with an alternative lipid emulsion when possible, meaning when it is available. There are inadequate clinical trials to prove that one of the alternative intravenous lipid emulsions is superior to another. Results are likely to be patient, disease, and dose specific. However, one strategy is to base the choice upon the known biological effects of the constituents or mixtures of the lipid emulsions. While some patients will benefit from an immune-neutral lipid emulsion, others may benefit from an emulsion with inflammatory immune suppressive effects. How long will it take for the effects of the emulsions to begin, and how long will they last? The effects of the lipid emulsion infusions begin almost immediately. Fatty acids are removed or cleaved from the lipid micelles and enter the cells. This occurs within minutes to hours following administration. Overall, the effects will depend upon dose, body stores of fatty acids, and mobilization of endogenous fatty acids. Effects will last through infusion and persist until body stores of infused body fatty acids are depleted. We'd also note that body lipid content is continuously changing, so as you add lipid, the lipid integrates into the cells and then is mobilized. And this is a continuous process. How often should lipid be administered as a component of complete parenteral nutrition? For prevention of essential fatty acid deficiency, intermittent dosing appears to be adequate. However, metabolically, continuous daily dosing is more beneficial for supporting metabolic functions, which are also continuous. It limits hyperglycemia, supports the adaptive phase of the injury response, and provides substrate for cell replication and repair. Lipid is a component of balanced nutrition, which supplies all nutrients together at the same time. I often ask people, would you administer glucose as an energy source just twice weekly? What does it take for a lipid emulsion to have a clinical claim? All lipid emulsions for adults have a similar indication in the U.S. They're indicated as a source of calories and essential fatty acids for parenteral nutrition when oral or enteral nutrition is not possible, insufficient, or contraindicated. A clinical claim would require randomized, double-blind trials of adequate numbers of patients to support the claim, very similar to a drug. It is unclear what the clinical claim for a specific lipid emulsion would be. In general, a claim would require a clinical outcome, not just a biochemical outcome. In this slide, I present a number of myths regarding lipid administration in the hopes of clarifying the effects of lipids in humans. Number one, the clinical response to a lipid emulsion can be predicted based upon the fatty acid profile of the emulsion. This is not true. The effects of the emulsion depend upon dose, disease, patient characteristics, accompanying fatty acids, form of the lipid, and numerous other factors. Clinical trials are required to determine the clinical response to different lipid emulsions. Number two, all fatty acids produce similar biochemical effects. Fatty acids have different structures and they're metabolized by different pathways, all producing different biochemical effects. Number three, N3-PUFAs are immunostimulatory. While it is true that some metabolic products from N3-PUFAs may be immunostimulatory, as a whole, the effects of N3-PUFAs are anti-inflammatory and immunosuppressive. Number four, N3 and N6-PUFAs are antagonistic. N3 and N6-PUFAs may be antagonistic in certain pathways, while in others they act synergistically. Many of the synergistic effects of these fatty acids depend upon the number of double bonds in the molecules. Number five, the predominant effect of lipid intake is to prevent essential fatty acid deficiency. Probably the number one effect of lipid is to supply energy, However, it is also important to prevent essential fatty acid deficiency. But as we discussed in this presentation, lipids have many other effects in the body, including modulation of immune functions. Number 6, inflammation is a detrimental effect in hospitalized patients. In general, inflammation is good and beneficial and required for healing and recovery from illness. Number 7, most patients suffer from an overactive inflammatory state. While it is true that some patients may have a hyperinflammatory state early on after illness onset, most patients who are in the hospital will have an underactive inflammatory state and suppressed immune system. Number 8, the metabolic benefits from lipid emulsions can be obtained by administering the emulsion at biweekly intervals versus continuous administration. Most metabolic products are continuous, and the metabolic benefits of lipid administration are best obtained when the lipid is administered in a continuous fashion. In summary, clinolipid, an olive oil-based lipid emulsion, is high in omega-9 MUFA. Omega-9 MUFAs are considered immune neutral. In a large clinical trial of elective surgery patients requiring parenteral nutrition, olive oil-based lipid emulsion was compared with a 100% soybean oil-based lipid emulsion as part of complete parenteral nutrition. Olive oil-based intravenous lipid emulsion was associated with a significantly lower inflammatory status measured with prealbumin and a significantly lower incidence of infections. Of note, the trial was conducted with a ready-to-use triple chamber bag containing an olive oil-based emulsion. ASPEN and SCCM recommend substituting an alternative lipid emulsion, such as an olive oil-based preparation, for soybean oil-based lipid emulsions in critically ill patients. Please see the following slide for indications and important risk information, including the black box warning. Clinolipid injection is indicated in adults for providing a source of calories and essential fatty acids for parenteral nutrition when oral or enteral nutrition is not possible, insufficient, or contraindicated. Limitations. Clinolipid injection is not indicated for use in pediatric patients because there is insufficient data to demonstrate that clinolipid injection provides sufficient amounts of essential fatty acids in this population. The omega-3 omega-6 fatty acid ratio in clinolipid injection has not been shown to improve clinical outcomes compared to other intravenous lipid emulsions. Warning: deaths in premature infants after infusion of intravenous lipid emulsions have been reported in the medical literature. Autopsy findings included intravascular fat accumulation in the lungs. Preterm infants and low birth weight infants have poor clearance of intravenous lipid emulsion and increased free fatty acid plasma levels following lipid emulsion infusion. The use of clinolipid injection is contraindicated in patients with the following: 1. Known hypersensitivity to egg or soybean proteins, the lipid emulsion, and/or excipients. 2. Severe hyperlipidemia or severe disorders of lipid metabolism. The following are important risk information regarding the use of clinolipid. Stop infusion immediately and treat patient accordingly if signs or symptoms of a hypersensitivity or allergic reaction develop. Monitor for signs and symptoms of fat overload, essential fatty acid deficiency, and infections, including laboratory test results such as leukocytosis and hyperglycemia, and frequent checks of the parenteral access device. Carefully monitor severely undernourished patients and slowly increase their nutrient intakes while avoiding overfeeding to prevent refeeding complications. Frequent clinical and laboratory determinations are necessary throughout treatment. Monitor fluid status closely in patients with pulmonary edema or heart failure. Content of vitamin K may counteract anticoagulant activity. Clinolipid injection contains no more than 25 micrograms per liter of aluminum. There is an increased aluminum toxicity risk in patients with impaired kidney function, including preterm infants. Parenteral nutrition associated liver disease has been reported in patients who receive parenteral nutrition for extended periods of time, especially preterm infants. Monitor liver function tests. If patients develop liver test abnormalities, consider discontinuation or dose reduction. Reduce doses of clinolipid injection and monitor serum triglyceride levels in patients with serum triglyceride concentrations above 400 milligrams per deciliter. The most common adverse drug reactions reported during clinolipid injection clinical trials were nausea and vomiting, hyperlipidemia, hyperglycemia, hypoproteinemia, and abnormal liver function tests. Thank you for listening.